Hello, I'm Jan Basile and I'm speaking here with Dr. Phil Gorelick about preventing the first and recurrent stroke at the annual meeting of the Southern Medical Association. Our focus is on risk factors and options for best available therapies in preventing the first and recurrent stroke. Phil, what's the population attributable risk, or PAR, and which stroke risk factor has the highest risk for stroke, and why is this so important to look at it in that way?
Well, Jan, the population attributable risk, or PAR, represents the percent of stroke or other disease that's explained by a certain risk factor. The most important risk factor for stroke, or the crown jewel of stroke risk factors that are modifiable, is high blood pressure. That explains at least 25% of stroke and maybe up to 49 or 50% of stroke. So doctors in the audience need to know the most important thing that's modifiable and that they can treat is hypertension.
Right. So although a particular risk factor like MI, might be associated with stroke, because MI is so infrequent and hypertension is so prevalent, even though each hypertensive may be less likely to get stroke, as a population, it's hypertension.
Exactly.
Yeah.
The 1, 2, and 3 most important modifiable risk factors: hypertension, hypertension, and hypertension.
Very good. So my patient has had a stroke, and I need to go through how to prevent a recurrent stroke. In terms of antiplatelet agents, how should I approach that, and what's the evidence suggest in terms of preventing a recurrent stroke?
Okay. Antiplatelet agents, very important in our armamentarium for recurrent stroke prevention. We follow the AHA guidelines, which were recently updated this year in 2011. And what we have is a choice of any one of the following 3. You can use aspirin, 50 to 325 milligrams per day, clopidogrel, 75 milligrams per day, or aspirin plus extended release dipyridamole, 25, 200 twice a day. So you have your choice of any of those agents that you can use. So how do you select?
Yeah.
That's probably going to be your next question. We get that question all the time. Okay. So aspirin, one of the most cost-effective drugs in this area, pennies a day, but it only reduces 1 in 6 strokes. So it has a ways to go. Aspirin plus extended release dipyridamole and clopidogrel went head-to-head in a study called PROFESS, which was a recurrent stroke prevention study of over 20,000 people worldwide, and it turned out that it was a dead heat. Both of those drugs were just about the same. You couldn't split them in terms of risk of recurrent stroke or stroke, MI, and vascular death. Pretty much a dead heat. So you have to decide what you're going to do in your practice. Those drugs are probably a little better than aspirin, and that appears to be the case certainly for aspirin plus extended release dipyridamole. And so if you want to go to the next level, a lot of people would say if you have cardiac disease, you may want to go with clopidogrel. For the other people, if you want to go to that next level, which is a little more costly for the patient in terms of dollars, you might want to use aspirin plus extended release dipyridamole.
Interesting. So my next question would be, is there any evidence for aspirin and
clopidogrel? Yes, of course. So how do we answer that question? Well, the first study that came through was the MATCH trial, where aspirin plus clopidogrel were pitted against clopidogrel. And what happened there was that there was no major difference in the primary efficacy outcomes that I've previously mentioned. However, aspirin plus clopidogrel increased the risk of life-threatening and major bleeding by about 2 to 3 times. So because there was no efficacy advantage and there was a bleeding side effect that was major, we've stopped recommending aspirin plus clopidogrel for recurrent stroke prevention unless there is some compelling indication, such as stent placement or a patient who has acute coronary syndrome or one of the cardiac indications.
Wow, that's important, because you know, so you're on aspirin and you weren't on enough, so now you're going to go to the 325. You don't have to go to the 325 BID or 650 BID at one time was thought of, but now you're not going to use Plavix and aspirin. If they fail on aspirin, you're just going to go to Plavix and stop the aspirin.
That is probably what you're going to do. Furthermore, recently, within the past few weeks, the SPS-3 study, which was looking at prevention of small deep infarcts or subcortical infarcts, LACUNs, was pitting aspirin plus clopidogrel against aspirin this time. The study was stopped, and it was stopped in the antiplatelet arms of the study because of bleeding. Guess what? Aspirin and clopidogrel, too much bleeding, so they stopped that study. The other arm of the study, which is the all-important blood pressure lowering arm, is continuing on. We will hopefully know within a couple of years about that effect. Bets are, you're a hypertension expert, you know the answer.
Yeah.
Blood pressure lowering will probably win out, the more aggressive blood pressure lowering.
Yeah, that's interesting. So shift gears just a little bit, talk about atrial fibrillation, stroke, devastating consequence of atrial fib. How do you recommend, as a neurologist, knowing the literature as you do, the decision to use warfarin or one of these new antithrombotics like dabigatran?
Okay, good question. Strokes and AFib, higher mortality, more severe, as you've already indicated, something we definitely want to prevent. Right. Okay, so what do? AHA guidelines, again from 2011 for recurrent stroke prevention. What we found is that whether you have permanent AFib or paroxysmal AFib, and we finally learned that paroxysmal AFib is a big time risk factor for stroke occurrence. We used to, you know, waffle and waver about it. No more. We've got enough data to show that it's a major risk factor. So you got paroxysmal AFib or persistent, you get anticoagulation. So how do you choose them? Well, warfarin, narrow therapeutic index drug, a number of drug-drug interactions, a number of food-drug interactions, and it's estimated, as you know so well, that up to about half or more of people who should be on it aren't taking it. Doctors and patients aren't happy with it. However, despite some people's unhappiness, it is a drug that works very, very well. 60 to 80% relative risk reductions. Now, how many drugs do that for you? And far better than antiplatelet therapy with, for example, aspirin. It beats it out big time. So, warfarin is a reasonable drug. It's cost effective. However, you got to monitor it. There's always this worry about bleeding. So we have new drugs, as you mentioned. Direct thrombin inhibitor is one of them, dabigatran. In the RELY trial, dabigatran was not only non-inferior to warfarin, but it was superior at 150 milligrams twice a day. That's huge. Not only did that happen, but brain bleeding was about 3/4 less than with warfarin. Let me repeat that, because this is what we're all worried about with warfarin, isn't it? They're going to brain bleed.
Sure.
Yeah. So about 3/4 less with dabigatran or dabigatran, however you wish to pronounce it. Now, two more drugs have come exploding onto the scene, and they are direct 10A inhibitors, and one of them is rivaroxaban. Today, the FDA approved rivaroxaban. Now, this is a little more controversial because it was non-inferior to warfarin, but it did not have the superiority over warfarin. A second direct thrombin inhibitor, apixaban, looked very much like dabigatran. Apixaban, similar CHADS 2 scores in the patients at entry, similar time and therapeutic range, given twice a day, just like dabigatran, and the data looked quite similar in terms of superiority and the efficacy outcome endpoints and the reduced risk of bleeding. So we've got a lot more to offer, and so how do you decide? Well, from a cost standpoint, warfarin may be cheaper. However, if you're a high-risk patient, reducing those strokes more robustly with the direct thrombin inhibitor dabigatran saves money over the long haul.
Yeah.
So that's something to consider. The other issue is, gosh, doc, I have to watch what I eat. I have to watch what other medications I'm on. I got to be monitored all the time.
Right.
No monitoring, no worry about most drug-drug interactions, no worry about food-drug interactions with dabigatran. So what about that 50% that we talked about of people who aren't taking an anticoagulant? This looks like, you know, the line is open to run for a touchdown here with this drug. So I think it's filling a big void and getting more people treated, and reduces the brain hemorrhage risk, which I think is huge for us.
But if on warfarin and doing well with an INR of 2 to 3, one might continue that strategy.
Good point. If you can keep the INR in a high time and therapeutic range, you're not going to beat warfarin from an efficacy standpoint. You keep it up there 60 to 65% of the time, you really don't beat warfarin with the other drugs. That's the secret.
Yeah, okay,
but
very good.
Can you get it up? Can you get it up there? I mean, we look at a lot of these community anticoagulation databases. A lot of times they're in the 50th percentile, 55%, 53%, and so on. So that's the key. You can't beat warfarin if the INR time and therapeutic range is high, as you've indicated.
Good. Okay, so my patient had a stroke, is doing well, is asymptomatic. As part of the workup, we did bilateral carotids. My question is, do you need to know that data? Because with that data, what would be the threshold for where you might suggest some intervention in the carotids, be it carotid endarterectomy, might improve outcome?
Okay, so if they're asymptomatic, I like to wait till there's 80% asymptomatic stenosis before I consider endarterectomy. However, the guidelines say as early as 60%, but I think the message here is that medical management has come a long way with statin agents and a lot of the blood pressure lowering and diabetes control and so on. And a lot of people think that the medical management can hold the line on that carotid plaque. And I think that there's a lot of truth to that. You'd probably agree with that. And so if they're not progressing and they're asymptomatic, I keep an eye on them. But what about the patient who had that TIA or that minor stroke? What are we going to do? That's the question. And this is really based on measurement of degree of stenosis. So once you get to 70 to 99%, endarterectomy is indicated. Very strong efficacy data for endarterectomy. 50 to 69%, not quite as robust, the result from the efficacy side for reducing stroke or stroke and death, but it still has a big role, okay? And it seems to work better in men and those who have a hemisphere TIA or stroke compared to a retinal TIA or stroke, but it's still indicated in women. Under 50%, excellent medical management is the way to go. So we base it on the degree of stenosis, essentially.
And is there any role for stent placement in the carotids?
Well, that's of course become very controversial. I'm glad you brought the question up because that's been exceedingly controversial. The European studies, ICSS, the EVA study, the SPACE study, all of them seem to move the data over to favor carotid endarterectomy, surprisingly enough. However, in the US, the CREST trial, which was published not too long ago, suggested that for people 69 years of age and younger, that the stent was probably a little bit better, and for those 70 and above, endarterectomy is better. Now, you get older, more complicated atheroma, more twists and turns of the arteries, probably harder to do this by putting a catheter up and an angioplasty and stent. So the direct surgical attack is probably easier for the older patients. What do I do in practice? Endarterectomy is true and tried since the 1950s. You have a good operator who knows what they're doing. It's hard to beat, and guess what? You get a warranty for 8 to 10 years. What car in the US gives you a warranty for 8 to 10 years? Endarterectomy does, okay? Data goes out for some 8 years or more, and it still holds up. So that's
That's
pretty
good.
darn good, don't you think so?
Yeah, and the stent data only is followed for how long?
Stent data is a lot shorter. We're only talking about 2 to 4 years right now, and so we're not sure. Now, we've started doing intracranial stents. The Sampras trial came around, so now we're going further up. Didn't go well. But the real heroes in that study were the medical management docs.
Right.
2 to 2.5 times better outcomes from the docs who are treating blood pressure, getting cholesterol down, treating blood sugar, getting the patients to exercise, have the proper diet. A triumph for the medical docs. So intracranial stenting, it doesn't look good right now. There were bleeding from poking the arteries and so on, and so good news, control those risk factors. You can get some really good outcomes.
Well, thanks, Phil.
Thank you, Jan.
And I want to thank you all for joining us at the annual meeting of the SMA.